We go first, right?
Can you guys hear me?
Yeah.
Can you hear me? Okay.
So, I go first, right?
You go first.
Yeah, so we're going to co-present. We never rehearsed this ahead of time. And the nice thing about co-presenting is just as you're dozing off and getting bored with one of us, you get switched up. So, as was mentioned, I'm a stroke neurologist. I treat, or I'm part of the acute stroke team at both sites in Edmonton, so the Grey Nuns and the University Hospital. It also kind of gives me different perspectives. I get to work in the Ivory Tower, but also from the Grey Nuns, I see kind of the more real-world community hospital type of scenario. And we're going to talk about what's happening or what's changing with stroke therapy, and in particular endovascular stroke therapy and pathways to get patients to the right stroke centers in Alberta. These are my disclosures. None are really relevant or conflicting for this presentation. Renee has no disclosures.
Well, I did try to bribe him with a coffee.
Yeah, I did not.
You did not accept it?
I did not accept the Tim Hortons coffee offer. Okay, so just a bit of background about stroke, and I'm sure all of you have been exposed to lots of stroke patients. It's a big problem, and it's a twofold problem. One is that stroke, unfortunately, is associated with fairly significant morbidity. So a lot of acute stroke patients, once they come into hospital, never leave. But an even more significant problem is the morbidity, and essentially what that means is that stroke leaves people disabled. It totally changes their lives. People that were previously independent land up with disability and land up, instead of going back home, land up in long-term care. And because of that, it's a very expensive problem or health problem in Alberta. So there's approximately 5,000 strokes a year, and the estimate for how much that costs for the first year or per year is around $370 million for each acute stroke, summed over the 5,000. And that's a large financial burden both to the system and to families. And as I said, really the biggest issue is that it leaves people disabled. Someone who is independent doesn't land up going home. So, and that is actually a big part of why I think acute stroke therapy is so important, why I'm so passionate about it, because really what we all do when, and you guys are part of the treatment pathways, is every time we successfully treat an acute stroke patient, we're able to take someone who's going to land up disabled and make them independent, and that's a big benefit both to families and overall our healthcare system and society. So just to remind you, there's two types of strokes. There's ischemic strokes, which are the vast majority, so these are about 90% of strokes. And ischemic strokes are strokes that are caused by a blood clot that is lodged in an artery and blocks off blood flow to an area of the brain, and that brain starts dying. So that's the majority of strokes, and that is, for most of this presentation, what we're going to talk about. The other type of stroke is what's called a hemorrhagic stroke. So essentially, now the problem is that a blood vessel has broken open and that you're getting bleeding into the brain. And this, from your perspective, the one interesting thing is that people have tried to separate these out in the pre-hospital setting. And there's really nothing clinically that is a reliable way of separating out a hemorrhagic and ischemic stroke. So when you're transporting a patient, really you don't know which one it is. There are sometimes some clues like headache or dramatic spikes in blood pressure, but you can actually see that with both types of stroke, and it's not reliable enough to separate out the two. So ischemic strokes are a time-sensitive problem, and probably out of all the conditions that you transport other than trauma, it's the most time-sensitive issue. Because what is happening, and when you're transporting a stroke patient, one way to visualize what is going on within their brain is that that brain tissue is dying, and the amount of brain tissue dying increases dramatically over time. And it happens quickly, within minutes. And just to give you an idea, this is, people have done calculations on how much brain tissue dies per minute. So you lose, for each minute that acute stroke grows, you lose about 1.9 million neurons, which another way to view it, this isn't highlighted on there, but it's listed in terms of accelerated aging. So for each minute that a blood vessel remains blocked, it's equivalent to 3 weeks of accelerated aging for that person's brain. So that's the bad news. The good news is we can actually stop that infarct from growing. And on a very basic level, it makes sense. If a blood vessel is blocked and brain tissue is dying because it's not getting enough blood flow, the way that you stop that process is by opening that blood vessel and restoring blood flow. And the sooner you do it, the quicker you can halt this process. And the earlier you halt it, the better the patient is going to do. So we have two ways of restoring blood flow. And if I gave this talk 2 years ago, there would be only one way. It's probably the one that you're most familiar with. It's an IV medication that dissolves clots, TPA. And TPA is given intravenously, and it can remove and dissolve that clot and restore blood flow. What has happened in the past year and a half is there's been a dramatic improvement in dramatic advance in acute stroke therapy. And we now have a second, arguably much better, more effective way of restoring blood flow. And this is a mechanical device, or a series of mechanical devices. These types of devices are called stent retrievers. And these are a bit different from what you're used to or used to hearing about in cardiology. So the way these stent retrievers work, let me just see if I can, oops. I don't know if there's a pointer.
Top button.
Top button. Okay. Yeah, so the way these procedures work is that there's a guide wire that gets first inserted through the clot that's blocking the blood vessel. Using that guide wire, that can be used to guide this expandable stent into that clot. The stent is opened up, and unlike in cardiology where the vessel is stented open and the stent is left there, what happens here is the stent is pulled back and the clot gets stuck in that mesh. And then what you land up at the end of the procedure is a stent that is retrieved and clot stuck in the stent material. And that is dramatically more effective as a method of opening up a blood vessel. So although that sounds intuitively like a really good idea, whenever in medicine we want to know whether a good idea truly works or not, we have to do a clinical trial. And what was done over the past couple of years, this study was really based in Calgary, and at both Edmonton and Calgary were by far, it was an international study, we were by far the highest enrolling centers in the world. And what happened is that people were randomized to two therapies. So the medical therapy refers to what was the standard of care. So these patients, if they came in within 4.5 hours, would have got TPA and then admitted to the stroke center and got regular medical therapy. So the other group were randomly assigned to those stent retriever devices, and they received endovascular treatment. And this is the primary result of this trial. So really, kind of the group you want to focus on. It's actually kind of hard doing this backwards. But it's this number of patients that were disabled. So these are patients, the white are patients with good outcomes. So in the TPA regular medical therapy arm, about 29% would have a good outcome and 52% were left disabled. In patients that got treated with the stent retriever, what happened is that number of patients with a positive outcome increased dramatically, almost by around 20-25%. And that's a huge, so these are patients, for every one of these red patients, these are patients, disability is measured on a scale. These are patients that would have landed up in a nursing home. So, you know, you're taking patients that would have otherwise been left with substantial disability, sending them home. That's a big impact on outcomes and healthcare costs. So these endovascular therapies worked dramatically well in this one trial. And this was replicated by 4 other trials that were all kind of came out and being done at the same time. All showed a very similar finding that endovascular therapies do a much better job than TPA at opening blocked blood vessels. So this slide just says that, you know, essentially now that after these trials, both of these are standard of care. TPA still plays a very important first-line role. It's something that every patient can get at every acute stroke center, but for patients with certain characteristics, endovascular therapy is now becoming the second-line treatment of choice. So which patients do these endovascular devices work better for? And the simple answer is patients where there is a big clot blocking up a large blood vessel. So this is an example of a CT scan, and the big clot is labeled with big clot. And this right vessel here is the middle cerebral artery, and the brightness in the artery is clot. So what you can see on this non-contrast CT scan is that there's a couple of centimeters of clot there. And usually the clot doesn't just stop there. It sometimes starts all the way in the neck and extends up to the brain. So patients can have anywhere between 1 or 2 centimeters of clot up to 10, 15 centimeters of clot sitting blocking their artery. And you can imagine that if you give TPA, an intravenous medication, by the time it gets to the artery, it's not in a high enough concentration to really kind of eat its way through this whole several centimeters of clot. So these are the patients that do much better with endovascular therapy. And what's really exciting about this pathway we're going to talk about is we actually have a way pre-hospital to identify which patients are most likely to have these big clots even without the CT scan. So I'll tell you more about that a bit later in the slides. This is just to remind you of how stroke is organized in Alberta. There's primary and comprehensive stroke centers scattered around the province. Primary stroke centers are centers that have TPA capability. And then there's only 2 comprehensive stroke centers in the province, Foothills and the U of A Hospital. Those hospitals can do both IA TPA and the endovascular or stent retriever type therapies. This just is making the same point that I just made, that IV TPA can be given anywhere, but the comprehensive stroke centers are the only ones that can give endovascular therapies. So really, the next slides, what we're going to talk about is, so we have only 2 centers in the province that provide what is now the standard of care for treating large vessel strokes. So what we're going to talk about now are what are the pathways so we can ensure that patients across Alberta, not just the ones that live around the university hospital, get access to what is the best therapy for treating strokes. So I'm going to hand things over to Renee.
So, okay, good, there we go. So in light of what Dr. Buck just presented with endovascular therapy being such an effective treatment for large vessel strokes, it was recognized by the Cardiovascular Health and Stroke Strategic Clinical Network and the Stroke Program partnered with the Quality Improvement Clinical Research Project, and that's a project that's actually working with the stroke centers to improve their door-to-needle process, or some of you may have heard their stat stroke process. But it was recognized that we needed to increase access to EVT for patients with acute ischemic stroke across the province. So what they did is they proposed that we needed a system redesign, basically, right? So starting with EMS, because you guys are the first ones on the scene, right? We need to make sure that you are recognizing these patients who may be eligible for EVT, and then we've come together to kind of lean out how you would recognize these patients for you in the field. So what we did is we came together and we decided that we needed a provincial standardization for last seen normal and for what we call those acute disabling strokes that you call now, based on your red findings and last seen normal. It varies across the province, believe it or not. It varies across facilities. So we came together and we've built a provincial standardization, which I'll go over in a minute. As Dr. Buck had mentioned, the LAM score, or the Los Angeles Motor Scale, is a validated tool that's going to help you recognize these large vessel occlusions, these patients that are eligible for EVT. Okay? So we'll go over that as well. And then field communication, which is the strategy that I'm going to talk about here shortly. As well, working with the primary stroke centers to improve their CTA capabilities. Some of them are, don't offer it maybe 24/7. There's some challenges, getting staff in. So they're really working with these centers to improve their CTA capabilities, which is really important in getting that diagnosis and getting that patient off to where they need to go more faster. So we brought together numerous stakeholders across the province. So we brought together various departments within EMS, so one being quality and patient safety, what I was a part of, as well as learning and development, STARS, IFT fixed wing. We brought medical first responders, frontline practitioners we had involved. We had our EMS medical directors involved. As well, we brought in, I already mentioned STARS, but stroke teams from across the province, and the primary and comprehensive stroke center. So some of the emerged physicians, nurses, et cetera, et cetera. So as a group, as I mentioned, we aligned our provincial standardization for last seen normal. So currently, like I said, it differs across the province. When this strategy is implemented, December 5th is the planned implementation date. So when this strategy goes live, your last seen normal is going to become 6 hours or less. Also included in that is if the patient woke with the symptoms. Your red findings are going to remain the same, those red findings on that provincial EMS stroke screen. However, we've added arms drift down as red findings. Reason being is there are a number of patients who may only have that symptom, but they may be eligible for TPA. They may be eligible for EVT, but we've added that as a red finding. So please remember that. So currently on your EMS provincial stroke screen, right, you have one or more red finding plus your last seen normal, right? That's called an acute disabling stroke. December 5th, and some EMS services are already doing this, they're calling it a stat stroke now. So December 5th, it's a stat stroke if you have a patient who is last seen normal, 6 hours or less, or woke with symptoms, and has one or more red finding. So that's going to be the new provincial nomenclature, stat stroke. So this is the LAM score. So the beauty of the LAM score is it already includes categories that are in our EMS provincial stroke form, right? So your facial smile, your hand grips, your arm strength. What it does is it assigns a number to the findings, right? This is hard. Oh, it has to hold it. So it assigns a number based on what the finding is, right? So, for example, if you have a right facial droop, and I just also want to mention, you're just scoring the affected side. So if you have a right facial droop, you're going to get a score of 1. If you have a weak right hand grip, you're going to get a score of 1. If your right arm falls rapidly, you're going to get a score of 2. Add that all up, it's a score of 4. This scale is on a scale of 0 to 5. Okay? Those patients who are eligible for EVT is patients who have a LAM score of 4 or greater. So just to recap, because this is important when I go in to talk about the strategy. So stat stroke definition is one or more red finding on your EMS stroke screen. Please don't use the Cincinnati stroke scale. The Cincinnati stroke scale is interpreted in our EMS provincial stroke screen with some additions. So we just don't want you to miss any patients, so please use the provincial EMS screen that is provided. And it is on your documentation, on your PCR. So one or more red finding and you're last seen normal is 6 hours or less, or you woke with symptoms, okay? So that's your stat stroke. And then you're EVT eligible if you have a LAM score of 4 or greater. So the pre-hospital communication strategy. What is it and why are we doing it? So it's a scene call between the EMS practitioner, a stroke neurologist, and a transport physician. Also on the line, just to be completely transparent, RAPID's, the STARS Emergency Link Center, and AHS Dispatch will also be on the line listening and doing what they need to do in the background. Okay? Why are we doing it? Well, we're doing it to confirm EVT eligibility. So meaning that if the patient is EVT eligible, then a decision will be made whether they should be transported directly to a comprehensive or a primary stroke center. And also determine the safest, most efficient mode of transportation to get that patient to the most appropriate stroke center. Who triggers it? So you guys in the field. So you arrive on scene, you assess a patient, all right, you've got a stat stroke, you do your LAM score, you've identified that that patient has a LAM score of 4 or greater, great. That patient is potentially EVT eligible, what do I do now? Okay, before we go on to that, so who here works in metro centers? Okay, so this isn't really applicable to the metro centers, okay? The reason being is by the time you get all those folks on the line, you're gonna be on the doorstep of the hospital. So what we want you to do is transport to your comprehensive stroke center and pre-notify that hospital that you're coming with this patient, okay? Who here works rurally? Great. So this is where the strategy is going to come into play, and we'll discuss that in a second. If you're in a center, so if you work in the Red Deers, the Grand Prairies, other centers, Camrose, for example, that have a primary stroke center, just go directly to that stroke center and pre-notify them, okay? We want you to do it prior to leaving the scene, all right? We want you to do it as soon as you assess that patient, make that call. So how do you do that? You call your OLMC number that you usually call. Don't ask for OLMC. What we want you to do is say, I have a stat stroke patient with a LAM score of 4 or 5, depending on what your score is. And what that's going to do is that's going to trigger that person that answers the phone at OLMC, that communication person that you usually talk to when you ask for OLMC. They have a procedure in place where that triggers them to get the transport physician and the stroke neurologist on the line. And they also call RAPID and they bring in the AHS dispatch, and RAPID will make sense in a second. So what we want you to do is while you're preparing the patient to getting your assessments done, getting the patient ready for transport, you're going to be waiting for that stroke neurologist and transport physician to come on the line. And once they're both on the line, we want you to give a report to them. And this is the format that we would like you to use. And it was mentioned earlier, I think by Dr. Kawaroff, that this was potentially coming. It is coming. It is going to be a part of your standard approach. We've identified that this is a really great tool to use. It's very short, concise. It provides physicians, stroke neurologists, it provides your OLMC docs. If you're talking to triage, for example, even at the bedside, it provides them with a very clear, concise report, and it allows as a triage nurse, it allows us really early to identify what you're calling about, and while you're giving us a report, we're thinking about what we need to do. And it's the same with physicians. They're thinking ahead about what they need to do, and we can actually start initiating stuff if you state right up front what it is, and then you give a clear, concise history. So this is an example that we pulled from one of our simulations that we did with the EVT communication strategy, and Dave did give me permission to use it. So what now? Stroke neurologists, transport physicians on the line, you've given reports, now what happens? Well, you as an EMS practitioner, you're gonna stay on the line, you're still gonna prep that patient, maybe get them into the ambulance. We recognize that you have a lot going on scene. It's busy, there's typically only 2 of you, but if you can, we just really encourage that you work together and that you do make that call, and put it on speakerphone if you have to. It's fine if the patient hears and family hear what's going on in the background. That's a part of patient-centered care, so that'll meet that requirement of AHS. But yeah, just it's really important to trigger that early, because what happens is when you do trigger that really early, is it allows the folks in the background, particularly the transport physician, to really work on figuring out transport times to the different centers, what the weather's like. If they think it's going to be a go for stars, for example, then what can happen is that transport physician can pre-alert stars. Stars can pull the helicopter out of the hangar and do all their pre-flight checks, which can typically take 10 to 20 minutes depending, right? So there you've saved 20 minutes of time. And it allows the stroke neurologist to really just gather some information and have that discussion with the transport physician to determine the most appropriate center for that patient. So there'll be 1 of 2 decisions made. So direct to a comprehensive stroke center, or you're going to transport first to a primary stroke center to have your CT, CTA, possibly TPA. Okay, so we're going to just talk about direct comprehensive stroke center. So this is probably most applicable when you're a little bit closer to the metro centers, for example. You may be an hour or so out, right? But they may just decide that, it's probably, you don't need additional transport, you don't need to rendezvous with stars, you don't need to meet, another crew along the way. So they'll just direct you to go to the comprehensive stroke center. The beauty of Rapid and the STARS Link Center being on the line is they can actually, instead of you hanging up and then calling into the comprehensive stroke center to let them know you're coming, they can actually just patch you right through. Or they might even be able to pre-notify that comprehensive stroke center if need be, if you're too wrapped up in stuff. But it just prevents you having to make an extra call, right? So transport transport to a primary stroke center. So this is going to be most applicable for those rural settings where you're not really close to anything, right? If you're an hour or so out, and I don't want you guys to get hung up on how far you're out. You guys are the best judge of how far you are away from centers. But if you think that it's going to be quicker for the patient to say go by stars, or if you're really remote rural, if it's going to be quicker to go by fixed wings, then make that call, right? But if there's a decision to go to the primary stroke center made by the stroke neurologist transport physician, this is where Rapid comes into play. So what they will do is they will actually call the primary stroke center triage nurse and the neurologist on call if that center has a neurologist. If not, then they'll pull in the emerge physician. And then what's going to happen is the stroke neurologist on the call that you originally talked with is actually going to give that report to the triage nurse and that physician at the primary stroke center. Okay, you're still going to remain on the line. You're probably you're probably already starting on your way to the primary stroke center. But the reason why you're going to stay on the line is just so if that primary stroke center needs a little bit more confirmation from you as a practitioner that's with that patient, then it allows them to gather that information and also just to confirm your ETA. All right, so what happens on the call with this primary stroke center? I think I just went through that. I kind of skipped ahead, sorry. So we'll just keep going. So what happens at the primary stroke center upon arrival? So this is where I mentioned before that stat stroke process, right? So a lot of facilities are already, stroke centers are already doing this. As part of Quicker that I had mentioned earlier, that's working with the stroke centers to improve their door-to-needle process, or their stat stroke process. So what's going to happen is you're going to arrive at triage. They're going to direct you either to a bed, or the stroke team or the emergency team may meet you at triage. It just depends on the facility. But you're going to keep that patient on the EMS stretcher, and they're going to do their quick assessment. They're going to determine, okay, yeah, that patient is probably a stroke. Let's go to CT. If you're going to go to CT, you take the patient. So EMS practitioner takes that patient with the hospital team in tow. And then that patient will get their CT. We ask that you remain with the patient. Some facilities, require EMS's assistance along with hospital staff to help transfer that patient back and forth between CT table and stretchers. But also it provides you with the opportunity for education, right, to find out what the actual diagnosis is. And also, as part of this strategy, we hope that if the patient is confirmed EVT eligible, working with dispatch, what have you, that you as the primary EMS practitioner would then take that patient on to a comprehensive stroke center. Not always can happen. We recognize that there's challenges with limited resources in communities. Are you the appropriate practitioners? Like if you're a BLS practitioner and they've received TPA and they're on a drip, you might not be able to take them on. We would need an ALS crew. But while you're at the facility, Rapid and the primary stroke center, the transport physicians, and HS dispatch are working in the background to have that all figured out by the time that patient is done their CT, and we hope that you would have an answer on what you're doing, whether you're clearing or moving on to a comprehensive with that patient. So again, if the patient's not eligible, you just do what you normally do, right? Hand over to hospital staff to clear. If patient is eligible, then you, as the primary practitioners for that patient, would go on with that patient, or you would rendezvous with other crews, stars, fixed wing, what have you. Clear as mud? Okay, so we're going to go over some scenarios, and I'm going to let you do this.
So we'll just go over some quick scenarios just to kind of emphasize these pathways and some of the decisions that we go on during the call. Correct. Okay. So essentially, there's always one of two potential pathways. Again, unless you're working with an Edmonton and you're close to the U of A, then obviously the direct to the comprehensive stroke center would be the default anyway. But really, we have one of two choices. One is to take the patient to the primary stroke center where they've received TPA, or the other would be for them to go directly to the comprehensive stroke center. So how are we going to decide with you guys on these calls about which patients to take where? And the answer is that there's a number of different variables that we'll have to consider on a case-by-case basis. So if the primary stroke center is very close, as Renee already mentioned, the default is just take the patient to the primary stroke center. For patients who have very poor premorbid function, so a patient with advanced dementia that you pick up from a long-term care facility, the amount of help that endovascular therapy is going to provide this person to become independent, it's just not feasible. And from a system perspective, it's not cost effective. So those patients would go to the comprehensive stroke center. The less severe strokes, the ones where the vessel that is blocked is a smaller vessel that is beyond what we can see with our CT angiogram would be ones that are most likely to benefit from IVTPA anyway, and they would go direct to the comprehensive stroke center. And then there's all these other variables, like how far you are from the comprehensive stroke center, what the weather is like. Patients that might go direct to comprehensive stroke center rather than first to a primary stroke center are exactly the opposite of what I described. So these are patients who are younger, good premorbid function, and patients who have most likely a large vessel occlusion. And remember, you're going to be determining this from that LAMP score. Just to tell you just a very quick bit of background, because I think it always is helpful when you're learning a new scale to understand that it's not just this arbitrary scale that people kind of made up and are forcing you to add to your probably 10 or 15 other scales that you may have to learn. So this scale was validated, and what they did is looked at patients with large vessel occlusions and tested it with the scale, and they came up with that threshold of 4 as being about 80% sensitive and specific. So what that means is that 80% of the time when you have a patient with a LAMS of 4 or more, it's a big blood vessel blocked and a stroke that is potentially amenable to endovascular therapies. What that means clinically, how that translates that LAMS of 4 to what you're seeing in front of you, well, these are the patients. This is not the 90-year-old who kind of is in long-term care, wakes up in her porridge, and they report that her face is a little bit asymmetrical. These are the patients where their limb is dropping, they're not communicating at all, they're globally aphasic, they've got a big gaze deviation. These are the severe strokes. What is going to go on during the two-way communication? When I look at this slide, I think the answer is we're not sure. I think that is true. Like I sort of present it half jokingly. I think there's going to be a lot of individual variables that we're going to have to take into account. It doesn't really lend itself well to an algorithm. And there's things like when the patient was last seen well, how good they were doing, premorbidly, and also variables like weather that are going to lead us to decide who goes to the primary versus comprehensive stroke center when you're not close to either one of these two places. And I think this is a process that we're going to have to refine, again with your help. One of the things that I think we probably need to build in is a feedback mechanism where you can also kind of give us, because this is a very new process, feedback on how these calls go and how you found the pathway, so we can keep making changes as time goes on. So we already talked about this LAM score, and as I said, it's not just an arbitrary scale. It is validated, and we've kind of demonstrated that it is the best way of simply identifying which patients have a large vessel block. As far as scenarios, when you're close to a comprehensive stroke center, it's easy. Go directly to the comprehensive stroke center if you have a severe stroke. In urban or rural scenarios, if you're close to a primary stroke center, again, just go directly to the primary stroke center. And these are the types of scenarios where these three-way calls are probably going to be the most helpful. These and this was developed, these slides were made in Calgary, so I don't know how to translate the equivalent in northern Alberta, but it would be maybe, where you're like an hour out of Camrose and 2 hours from the university hospital. Those are the calls where it would be helpful to have a discussion with you. So a patient, who's 50 years old, who's got a LAM score of 5, who's, densely paretic and aphasic, we may decide that that patient would be better with an hour longer transport to be directly at the university hospital, because there's a really good chance that that patient, after TPA, is going to go straight up to the cath lab and get thrombectomy. So how are you going to kind of learn all this new information that we presented today? I don't know the answer, but I think we need that.
I do. Can you guys hear me? All right, so So Quicker, that parallel project that I mentioned a couple times, they are working on education modules for all, 5 minutes, for all, does that include questions? Okay, so they're working on some education modules for all healthcare practitioners that care for stroke patients. The reason that they are doing this is they just want to make sure everybody is educated the same way, they have all the same information, we're all on the same page. It makes a standard across the province, and it just provides healthcare practitioners with what am I supposed to do with this patient. Okay? EMS Symposiums, we are presenting at all the EMS Symposiums this fall. I will be presenting, Dr. Demchuk is a stroke neurologist in Calgary, and I will be presenting at the next EMS telehealth session November 14th. So if you want to attend round 2, come and join us. As well, we have changed the we will change the EMS provincial stroke screen. So it will have that arm strip down. That's now going to be a red finding added, as well as that LAM score is going to be there with some direction on how to score it. And then also we are providing some direction on what am I supposed to do with that LAM score, where am I supposed to go, who am I supposed to call. As well, we will be revising the EMS Adult Stroke MCP, so that will be released December 5th with implementation. So please keep an eye out on your app for the update. As well, there's going to be a memo that will be sent out, which will outline all the changes and discuss the strategy to help remind you. We will have a couple of minutes for some questions, but unfortunately, Dr. Buck and I can't stay much longer. I have to travel back to Calgary, and I'm sure he has patients to see. So, but you can email me. It's renee.villeneuve@ahs.ca. You can find me on the AHS directory quite easily, or somebody from your Learning and Development Department. Or TPS can direct you to find me. So, questions, please.
So how does the strategy of the new stroke truck out of Edmonton work into this, that they're going to be manning?
The stroke truck, yeah.
Oh,
Yeah.
yeah. It seems like I've learned. We always get that question. So the stroke ambulance is, I believe now, still delayed another couple of months, so probably early in the new year. And we still haven't worked out the transport protocols for the stroke ambulance. I think the plan is for it to rendezvous midway between primary stroke centers and the comprehensive stroke center, and help administer TPA at an earlier time point. But I don't think the numbers of patients that are going to be transported, like I would view that the first year as really kind of a research and pilot project. I don't think it's going to have a big impact on routine clinical care of stroke patients, at least not in the first year. So I don't think I've really answered your question, but part of the thing is I think we don't really know yet, and it's probably not going to have a big impact initially. It's a pilot project.
Yeah, so you mentioned that sometimes they might get TPA and then go for the EVT. Is there a threshold at which TPA is more effective if it's given like really early in the disease process, or is it sort of both?
Yeah, so the earlier you give it, the more effective, the more likely it is to lyse the clot, and the smaller the clot volume, the more likely it is to lyse the clot. So that's why with smaller, milder strokes, we're still, early TPA is the first line therapy. It's those big strokes with a large clot volume where TPA really doesn't have enough efficacy to dissolve a 3 or 4 or 5 centimeter clot. Yeah, so it's smaller, minor strokes.
Sorry, second to that, which would patients be that would get the TPA and then still go with the...
So first line for everyone is going to still be EVT because not everyone is going to be eligible for endovascular therapy. Even patients with a large vessel occlusion, you can get them to the cath lab and there could be access issues or their vessels are too tortuous. And if we don't give them TPA, then they've basically got nothing. So I don't want to kind of minimize the role of TPA. Early EVTPA is first line therapy for stroke still. This is an add-on for patients with large, bigger, more severe strokes with large clot volumes.
Okay, we have time for 2 more questions. We're just going to go over here quickly.
That 6-hour window, is that a hard and fast rule, or is it patient by patient basis? And what happens, because we do some calls where we don't know how long they've been down for.
Yeah, so those are so a lot of those are wake-up strokes. So wake-up strokes we're still including in this pathway. We're giving them the benefit of the doubt. With a wake-up stroke, so someone who wakes up with their deficit, their stroke could have started the night before, like 4 minutes after they fell asleep, or it could have happened 10 or 15 minutes before they wake up. So those patients were still transporting under the acute stroke pathway. If you don't know the time of onset and they're not a wake-up stroke, then you go with the last known well time, and that rule we're kind of sticking with. So if their last known well was 18 hours, they would not be a candidate for these therapies. And the reality is most of those patients, unfortunately, by the time we get them to a CT scanner, there's already too much brain tissue damaged and not enough to save.
We have time for 1 more.
Sorry, I didn't want to.
With the release of the EVT study last week in JAMA on with the comparison to general therapies and the increase to the 7.3-hour, we're going to see that here, or the inclusion of the NMA1 into the protocol if it's proven successful trial?
Yeah, so I mean those are really good questions. I'll just kind of summarize for people who aren't familiar with the literature. So one of the questions, there's a compound called NA1, which is a neuroprotective compound. So the question is, can we actually protect the brain and slow that growth of infarct by giving something early on? And there is going to be a trial that is based out of Calgary where that compound is going to be given in the ambulance. It's a randomized trial, and we don't know whether it will work. Anyone in the Calgary region may be asked to participate in that, and that's really exciting. We're not yet sure whether we're going to be doing that in Edmonton. And then the 7.3-hour question is, and it kind of relates to the question about the 6-hour window. These time windows are rather arbitrary, and there's a lot of individual variability. And there is some evidence that patients even up to 12 hours may benefit from these therapies. So for right now, we had to kind of pick some cutoff time point. Otherwise, you'd be transporting, double the volume of stroke patients to our comprehensive stroke center. So we're sticking with 6 hours and wake up, which already is a big broadening of who we're defining as an acute stroke. Before it's 4.5 hours. So, but I think over time what's going to happen is that time window will start to move outwards. And are there exceptions to the rule? Yes. I would say if you have a young, healthy person that has a big, bad stroke, like you're transporting a 50-year-old that's at 6.5 hours, I would, give us a call or I would still preferentially lead that patient to a stroke center.
Awesome. Thank you so much, you guys, for allowing us to